My name's Kyle Kusnose. I'm the director of the Jones Institute and one of Brian Tuckey's instructors for the MSK-C course. So if you're within in the curriculum, you'll see me as both an instructor and I lab instruct all of the courses here out of our San Diego location. And Brian, do you want to introduce yourself as well?
Yes, hi everyone. I'm Brian Tuckey, the developer of Fascial Counterstrain. I developed the entire Fascial Counterstrain curriculum, and I'm one of the original four physical therapists who was personally certified by Dr. Larry Jones, the inventor of classic strain and counterstrain technique. And he certified me prior to his death in 1999. And then I kind of took over the reins of development and have advanced the technique from approximately 200 releases to what today is well over 1,000 different techniques. And again, what we're going to be talking about predominantly today is a little bit about the technique itself, as some of the practitioners, are not, some people on the web are not practitioners, but we're also going to talk about a very specific application of the technique in the world of capsulitis, fasciitis, and osteoarthritis.
Yeah, so what we wanted to do is we kind of continue creating this YouTube series is zero in on problems that the non-counter strainer is having, working with difficult patients. We started out really talking about adhesive capsulitis and the shoulder, and then the application of counter strain into that diagnosis really applies to not just the shoulder, but into other areas of the body as well, with a common thread of structures that we treat. So that's the focus of today's little in-service here. Um, and Brian, I know that you shared with me somewhat recently you had found a connection in the research with substance P and TGF-beta 1, further explaining how this proximal dysfunction can create these segmentally specific adhesions in the joints too. So excited to get into that with you as well today.
Yeah, we'll have some things that are, new for the current, practitioners who have logged in tonight. And then we're going to start with, briefly with some of the basics for people who are watching this type of presentation for the first time. So as Kyle said, we've just been, several times a year picking a small application of counterstrain, which, can be applied to so many different conditions. And we just kind of focus a webinar on a specific one. And as you said, many of you struggle with, adhesive capsulitis and plantar fasciitis. And we're going to talk about the shared pathophysiology behind these techniques and how we can address that as fascial counterstrain practitioners, which is quite different than, what we were taught to do in school, at least as physical therapists.
Can I ask you first, Brian, what's the, for the non-counter strainer, what's the problem that we're really addressing with the counter strain curriculum when it comes to joint capsule issues? Is it treating locally only? Is it not treating the right system? What do you see as being kind of the major deficit there?
Yeah, it's a misunderstanding of, again, the etiology of the condition. It's basically we were taught that it's a local entity that, particularly post-trauma, that may have caused a, migration of myofibroblasts and scar tissue to the capsule. But as, any of you on this feed know, many, capsulitis patients present bilaterally. Many of them, if not most of them, are insidious onset. There's no trauma. Yes, we see it post-operative, but, that's not the norm. Many of our plantar fasciitis patients, they get it in both feet, and it also comes on out of the blue. So we're going to try and answer some of those questions for you tonight as to how that is possible. If you didn't take up running or you didn't, jump off a dresser and bruise your heel, how do you just suddenly have fasciitis? Why is it on both feet? Why doesn't it respond to local treatment? Why does capsulitis come out of nowhere and end up often spreading to both shoulders? What are the commonalities, of these conditions? And we're going to get into some of that science. So, not to get too far ahead of our presentation tonight, but basically you'll see that many of these cases have a spinal inflammatory origin. That inflammation is produced outward and is affecting one or multiple joints. And if we can get to that spinal and inflammatory source and shut that off, then the capsulitis can resolve rather quickly.
Yeah. Yeah, and before we get too far into the science, I know you have some case studies that you wanted to show as well, just for those that maybe haven't seen this technique in action yet. I think
Yes,
that's
we'd like to start
a good place
off
to start.
by just showing a couple videos. I'll shut off this poll here. And just to give you guys an idea of, the technique, how rapid you can see changes. For those of you, again, who have no idea what this technique is, it is an indirect technique, meaning we basically decompress tissues, we drain swelling. We'll talk about that. It is painless. And because we're getting at the source, which is trapped inflammation, the carryover is really unprecedented. You'll see these two videos and the range of motion changes in both of these two, kind of video case studies, one treatment case studies here, were lasting. These patients did not need additional treatment to maintain the benefit that you will see here. So let's pop up here, do a share screen, and let's hit this guy here. All right. I'm going to hide my meeting controls. Apparently it's blocking everyone. So let's, all right. So if we, before we get to that, let's just reiterate what we just said a little bit. So what is fascial counterstrain? Well, it's a modern form of manual therapy. Again, really developed, starting in the 1980s with Dr. Jones. He kind of perfected it, started teaching it in the 1980s late. And then the modern version of fascial counterstrain really started developing that after his death in around 1997. And really, it's just been, 25 years in the making, really perfecting Dr. Jones's original work. But what it does, in a simple way of saying is that fascial counterstrainers, through a complex process, identify and then removed trapped inflammation in the body. And it's that trapped inflammation that causes chronic pain, continuously stimulates pain receptors, and then through reflex mechanisms that we'll show you guys in a second, also causes secondary muscle contraction, problems with the autonomic nervous system that can affect perfusion of artery flow in, venous flow out, and even cause neuron excitability, which makes neurons fire all the time. This particular presentation, again, we're going to focus on a very narrow application of fascial counterstrain, which is in those common orthopedic conditions, including capsulitis, fasciitis, and even post-traumatic osteoarthritis, and how we can really address that with the technique. So let's go ahead then and look at a couple case studies here. So this is a patient that had been in our clinic for a little bit of treatment for her frozen shoulder. And then the next layer that presented itself was the ligamentum flavum, spinal ligament at T3. And we're going to talk about the importance of that with regards to capsulitis in a few minutes. And you're going to see the changes with really just a handful of releases, maybe 5 minutes of work in her capsulitis, which have been going on for at least 6 months.
Okay, all right, we're going to take a look at a frozen shoulder here. This is Laura. She's been working with us, and we've got some motion improvements, but I just found a ligamentum flavum dysfunction at T3-4, which is key with frozen shoulders. And we're going to look at the before available motion, fix the ligamentum flavum, and then look at it again. So go ahead, Laura, and abduct for me, straight out to the side, and then stop when it hurts.
Well, actually, it hurts right there.
Right there. So
yeah,
basically can't go any further than 90 degrees.
At no hurting is right here.
Okay, very good. Now bend your elbow, and then I want you to try and rotate it back. And right there is all you can do, right? Mm-hmm. Pain right there.
The abduction, this is the worst one.
Yep.
It hurts right past here.
Can't even get anywhere near 90 degrees there.
No.
All right, great. Okay, so we finished the ligamentum flavum. We did one epidural vein, and we had to do a treatment of her radial nerve also, but the ligamentum flavum was by far the worst restriction. And then abduct again for me, Laura, all the way up. And there she goes. Okay, and down. Okay, and one more time. And so clearly not frozen. How's that feel?
A lot better.
Back down. Okay, good. Come back and let's do a side view and see how we did with some rotation. And
with this?
Yeah, reach back like that. Yep. Yeah, rotation now. It's much more normal.
Yeah.
Good. And then flexion for me, straight up. And there it goes. Very good. A lot better. Yeah. Not bad for frozen shoulder. Thank you.
All right, so again, that was a specific technique that was targeted to inflammation at the T3 level in the spine, and through some projected neurogenic mechanisms, which we'll describe, was not only contracting her capsule, but was giving her quite a bit of pain, which you could see in 15 minutes resolved. And again, that particular benefit was lasting. Looking at another one, which we're going to show you so we can refer back to this later. This was a lady who actually went to my church at the time. She had several different orthopedic conditions going on, but one central treatment of some musculoskeletal structures, ligaments, including the ligamentum flavum, to her cervicothoracic spine is going to resolve the whole presentation. So she comes in with some frozen shoulder presentation, capsulitis of her first CMC joint, and chronic neck pain. Treating that source inflammation in the neck actually resolves all the condition in a matter of about 20, 30 minutes of work here. So let's take a look at that.
So this is Jane we just assessed, and she's had a pretty significant limitation, neck motion, and then she's having progressive pain in her thumbs and a history of frozen shoulder on one side, both sides?
Frozen shoulder on both sides. I had one arm first, and then a year later I had the other arm.
I had the other arm. Go ahead and turn to the right, okay, and to the left. Okay, you get pain there? Mm-hmm. In this mid-back area?
And on the sides.
On the sides of the neck,
mm-hmm.
Okay. So what we found was a significant ligamentum flavum dysfunction, and that is responsible for frozen shoulder and also for capsulitis of the thumb. The T4 level is on the left side is dysfunctional, which associates with the thumb, and this is your bad thumb,
mm-hmm.
right? So if she abducts her thumb, so go ahead and bring that out to me. And you have pain right there?
Mm-hmm.
Okay. So that measures at just about 40 degrees of abduction on that side with pain. And let's do this side. Okay, bring that out as far as you can. Okay. And then this side, she's measuring over 50 degrees. Any pain on that side?
No.
Okay. So that's a mild capsulitis forming due to ligamentum flavum on this side. And then we're going to look at her shoulder, which was T3 dysfunction on the right. Laying your back here. This is a loss of external rotation. Okay, feel that pain right there? Okay, so she's coming in at about 60 degrees there.
Yeah.
Okay, versus her other shoulder, which has 80 or 90 degrees. Okay, so again, the T4 ligamentum flavum affects the thumb, the T3 affects the shoulder. We're going to treat those and then reassess. All right. 15 minutes later, and what we found were all musculoskeletal dysfunctions. We found ligamentum flavum at C5, C6, T3, and T4, as we knew. Found the anterior longitudinal ligaments at T1, T2, C3, and C4, and then the upper extremity T1 and C7 muscle chains, and we treated all those. And again, we're going to see how this has impact on the neck, the thumb, and the shoulder, which look to be unrelated problems. So first thing let's do is take a look at the thumb. So go ahead and pull open again for me. Okay. And we're going to go back. First of all, is there any pain there?
No.
None in the thumb. And then we'll look here at that alignment. And she's at almost 60 degrees now. So from, I believe we were at about 40. Okay. Much better. And to see that compared to the other thumb, open up both at the same time. Okay, and you can see those guys. Actually, if anything, this might be slightly further right now than the other side. And it feels good?
Mm-hmm. Feels great.
Feels great. Okay, so thumb of capsulitis and potentially progressing to arthritis is looking good. Let's go over and look at the shoulder. And we'll get in here, take a look at our shoulder external rotation now, which was limited at about 60 degrees, and now we're just going to drop. Okay, how's that feel?
Good.
Feels good, okay? So instead of hanging up and about here, okay, it's dropping all the way down. So big improvement in shoulder external rotation, and the pain stopped though, right? All right. And then sit back up, let's take a look at the neck. See on the front there, okay? And she also, of course, one of her main complaints when she came in was also neck pain. So let's turn left for me. Okay, very good. Any pain?
No pain.
And right for me. Okay.
Good.
Very good. So again, 3 different complaints, like a developing thumb arthritis, a residual frozen shoulder, and neck pain, all treated with musculoskeletal fascial counterstrain. All right, thank
All right. So do you have any thing you want to say there, Kyle, or I can just move on?
Question. Um, so, with some of these capsulitis issues, sort of the pathophys of it is fibrotic changes to the actual joint capsule, this excessive amount of collagen that's being laid down. These are structural changes, and yet patients are responding this quickly, um, within 15 minutes of treatment. So what's your kind of
Yeah,
take on that?
we're gonna talk about that, and I will get to that. But the 10,000 foot view is that certain cytokines, and one we'll talk about TGF beta 1, which is produced in response to other inflammatory cytokines, is actually able to make intrinsic capsule myofibroblasts contract. So as we drain out that TGF beta 1, those contractile cells that we now know through the emerging science over the last 15, 20 years, contractile cells in the capsule literally relax. So yes, there are cases where there's layers of that fibrosis, and it takes multiple releases, even a little time to
Yeah.
resolve. But in many of these cases, it is simply getting that specific cytokine out of that area, and it causes a relaxation of the intrinsic contractile tissues inside the capsule.
So some of these issues may still need to like unfreeze a little bit over time after release, but just getting the myofibroblast relaxation creates that dramatic of a change.
Yeah, there are cases where I've seen some long-standing difficult cases that obviously can take more than one session for sure, and cases where a lot of the pain drops down immediately, the range of motion gains 50-60% back, and then I might see them back 3 or 4 weeks later, and they've gained an additional amount just with things resolving over time, kind of peel off that next layer that we all see in manual therapy, and you can kind of treat it with a few sessions spaced out over time. That works very well with fasciitis. So unlike I'm sorry, with capsulitis, unlike the standard paradigm where you'll see a person 3 times a week, you'll just do passive range of motion and try and really just kind of blast through that. We're targeting the core inflammation that makes that capsule contract. And that core inflammation, as we'll talk about, is also what is stimulating the pain receptors. So, that particular lady, maybe she was still missing some range of motion here or there, but you could see, both those women had a smile on their face at the end because the pain went away. People don't really care that they only rotate 60 degrees. If you can get rid of the pain, that's what really what they're looking for. So what we ended up doing was I went down there, I talked to some of these world-renowned researchers, told them what we thought. Jay gave his testimonial as to how I was able to help him without really causing any pain and very rapidly. And they devised a microdialysis needle, and they went into active trigger points, pain-producing upper trapezius trigger points, and sampled the interstitial fluid with this tiny little needle. So they didn't get any blood, just the interstitial fluid. And then they compared that sampling to the uninvolved side where there was no pain in the upper trapezius. And what Dr. Shah's team found that there were 23 different chemicals related to inflammation, even catecholamines related to vasoconstriction, that were trapped in that area of the active trigger point. So that was a really a nice hallmark study that has been cited so many times since 2008. But it does show that there is in fact evidence, and there are more studies since that show trapped inflammation in these areas of chronic pain. So the next thing then to talk about is, what are the symptoms, I should say, of that trapped inflammation? And the first thing that we need to be aware of is that inflammation, pro-inflammatory cytokines trigger pain receptors or nociceptors. So as we know, inflammation causes pain. So this trapped inflammation in the interstitial space, first of all, causes chronic pain. However, when those afferent sensory neurons depolarize into the dorsal horn, so in this case, we have an inflamed ligament, triangular ligament of the liver, and dumping its, basically glutamate and substance P and CGRP, these various neurotransmitters that are dumped by these pain neurons into the spinal cord. And where that inflammation is dumped, it causes other reflex responses. And that's where you start to see more of this clinical presentation beyond just the pain. So the first thing you'll see is that inflammation gets dumped into the ventral horn, which is the motor area. So you get muscle guarding reflexes. So when those pain receptors fire in response to that trapped inflammation, you don't just get pain, you also get muscle guarding in that same segment, spinal segment. So for example, if you have a C6 problem, you can get tightness and contraction of the deltoid, the biceps, some of these C6 muscles as well. That same nociceptive barrage goes into the intermedial lateral column as well, and that is the area of that segment's autonomic nervous system. And what this causes is stimulation of what are called somatosympathetic reflexes, or SNA, sympathetic nerve activation, and that presents clinically as vasoconstriction at that segment and those same tissues. So now you get decreased artery flow and decreased venous return. So you have pain, you have motion loss, and now you start to get stasis. And there's even some additional impacts into the lymphatic system, which we'll get into the courses. But basically, so many things happen once you have an ongoing nociceptive barrage due to trapped inflammation. Okay, it's not just pain. And if you can get to this source inflammation and remove it from the body, you break all these reflex, responses. So it's really that a positive feedback loop that is, inflammation's causing contraction, causing decreased blood flow, keeps the stasis going. And we go in with our hands, we break this positive feedback loop that causes all the chronic problems. So I can take a break there, Kyle. Is there anything else you want me to touch on there before we move on?
I think you can either do it now or when you get into neuroinflammation, but just kind of zeroing in on neurogenic inflammation and exactly what that is, and differentiating it from neuroinflammation.
Yeah, so that's what it's on the bottom of the slide there. So what we just described there would be a source inflammation. So let's say we had an infection, a virus, or a trauma to an area, and that inflammation could be coming out of the area and then driving all those segmental responses, including muscle guarding and the vasoconstriction. But there's also something as a practitioner, whether you're physical therapist, massage therapist, anybody working with pain, you need to understand another concept, which is the concept of neurogenic inflammation, which is secondary inflammation produced subsequent to the primary inflammation going into the dorsal root ganglia and dorsal horn. So primary inflammations create secondary inflammation. So that's what we want to talk about next. So this is a slide that we have in our foundations course that talks a little bit about neurogenic inflammation. That's the word, nerve, genic, generated inflammation, okay? So we get this source inflammation, and in this diagram you have, let's say inflammation around a colon or that, a vessel, and that's our source. Those nociceptive neurons go in, dump into the cord, could create muscle guarding reflexes, autonomic changes, ... But what also happens when that source inflammation comes in to the DRG, dorsal root ganglia, and dorsal horn, it makes the body produce outward what's called retrograde, backwards, inflammation out to all the convergent other neurons that come into that segment. So for example, at any one segment, you would have pain neurons coming in from muscle tissue, viscera, the nerve sheath, the sheaths of the vessels, even the skin. And if one of these sources, like the viscera in this case, dumps inflammation in, that inflammation goes back out to all these other areas to some extent. It's neurogenically produced. That is actually how we have the formation of surface tender points. So we have tender points, all over the body. And it turns out that for each deep fascial tissue that sends in one of those source inflammations, if you will, there is a very specific patch of skin that shows up as a convergent sensory representation of that deeper inflammation on the skin. So any of these going in are going to create a unique skin tender point. So in the essence, Counterstrain, among other assessments, uses diagnostic tender points, which myself, Dr. Jones, et cetera, have correlated to the deeper source tissues. So you can get all types of secondary inflammation and not just that which goes to the skin and creates a tender point. All right. So the question then is, what else can this inflammation do? And that is where we're going to get into some of this newer science that even in the course as of last year was not really discussed in this updated fashion. But so the research shows us that the local inflammation is really kind of dominated by three specific cytokines that really create this whole problem. And if you look at chronic pain in sampling studies or other studies, there's really 2 or 3 cytokines that show up in all the chronic pain conditions. Interleukin 6, interleukin 1b, and another one is TNF alpha. And these particular 2 of these 3, interleukin 6 and interleukin 1b, when they, those cytokines are produced, they go into the DRG and they very specifically cause a very strong neurogenic response. And the body then dumps out into the periphery via that retrograde inflammation, substance P. Okay, substance P is again, neurogenically outward produced neurotransmitter. This can then create other inflammations. And you heard me in those videos talk about treating the ligamentum flavum. Well, we'll get to that anatomy in a second, but the ligamentum flavum, when it's a primary source inflammation, tends to dump inflammation outward neurogenically into capsules, okay? And those capsules that are involved, as a secondary retrograde inflammation are level specific. So for example, C1, C2, C3 will give you capsulitis of the TMJ. That T3-4 gives you glenohumeral. The T4-5 gives you the thumb, and it's segment specific. So any isolated capsulitis, which can progress to osteoarthritis, is very commonly sourced due to the ligamentum flavum inflammation at the cord. And if we treat that, not only does it unlock the neck, like you saw in the video, but then you can see the capsulitis virtually disappear, overnight or even in 15 minutes, because the TGF beta 1, which is produced by this, which I'll get into in a second, also disappears. And that's the one really doing the damage as far as making the tightening in the capsule. So what I just described here was then the source inflammation of any structure creates substance P, which goes out, will give you inflammation of another structure, maybe multiple structures. So one source inflammation could neurogenically produce 10 or 15 different tender points. And that's where a lot of therapists get in trouble is, they're just checking for tenderness, just checking for muscle tension. And what you don't have is a process to say, is that a secondary muscle guarding reflex? Is that a secondary neurogenically produced inflammation? Or is that a primary source inflammation? And there's really no way to answer that unless you go through a series of tests, which is really what we do with fascial counterstrain. Okay. So really what I've described here is how we could account for inflammation being projected out to distant structures. So again, those people with, insidious onset of capsulitis, if you look at them from a segmental motion sense, you'll see, again, it depends how many years you've been practicing, but you'll see that the C6, the C7, the T1, the T2, the T3 segments are almost always stuck in these patients. And those are the levels that dump out to the various joint capsules related to the shoulder. I'll show you a picture for the C6 and the C7, blends into the anterior capsule through some muscle chains. The T1, the T2 create AC joint capsulitis. And as I already mentioned, T3 gives you glenohumeral capsulitis. So cervicothoracic dysfunction from like being at a desk too much, having a whiplash, poor posture or time can eventually create inflammation that creates capsulitis in the extremities. Okay. So then the next thing, go ahead, Kyle.
Question here from one of the students is neurogenic inflammation related to dermatomes and referred pain?
Yes. So basically, in the chronic sense, absolutely. It is when you look at referred pain, we were kind of taught in school back in the day that it was, kind of a manifestation in the sensory nervous system only, which it can be. We can get into the brain and brainstem stuff, but as you know, you'll go down the leg of someone with like an L5 nerve root problem, and if you go down to their leg and their calf, and they're like, "Ow, boy, it's tender down there as well," there's actually inflammation at the other end of that sciatic nerve because the irritation was in the nerve root, and then it dumped all the way out into the periphery inflammation, right into the shin, right into the dorsum of the foot. We've all seen this. So it's not just pain being perceived in the brain, like phantom limb pain in someone who's had their leg cut off. It is actually produced into the periphery. So it is definitely one of the ways that you can get referred pain. Okay. It's a good question. All right. So let's talk a little bit now about, we've talked about the inflammation being projected. That's how you can get, referred pain. But what about referred tightness? Because that's kind of what we're talking about in this concept. So that, again, that gets into this TGF beta 1. And TGF beta 1, again, is if you have fibroblasts exposed to interleukin 6, interleukin 1b, they will change fibroblasts into myofibroblasts when exposed to the cytokines, and then start dumping out TGF beta 1. They will excrete it. So if you had an injury to the shoulder local, you could produce those cytokines and eventually get a capsulitis from a local trauma. This makes sense for, post-operative knees, injuries to the shoulder. But as we've been saying, many of these cases, they don't have an injury. Okay, I'll say, I didn't do anything. My shoulder just froze, and both sides are frozen. Or I have fasciitis on both sides. I didn't even do anything. Well, that gets back into this spinal projection. And there's some recent research that shows that substance P, which again is the neurotransmitter dumped out when you get this neurogenic pain, retrograde pain, this is able to stimulate local tissues to release TGF beta 1. So if you get enough of this neurogenic inflammation dumping from various sources into the shoulder, it will start to produce TGF beta 1, even though that isn't the source. So you don't actually have to injure the shoulder. Okay, any of these neurogenic projections to shoulder structures that shoot it back out can create the TGF beta 1, and you start to get that fascia contracting. Going back into 2019, Robert Schleip, a lot of you guys know who he is. He's a famous researcher. He proved in 2019 that if you take TGF beta 1 on human and rat ligaments, healthy ligaments, and just drip it on there, it instantly contracts. So all these tissues have intrinsic contractile cells or myofibroblasts, which it's written on the slide there, and just dripping TGF beta 1, they contract. So if we, through substance P, start producing TGF beta 1, you get a capsulitis. Okay. So the key is we just got to get that inflammation out of there. We don't got to start cranking on the shoulder, which, by the way, will cause pain, could stimulate nociceptors, which dump these chemicals, or, it could just cause local inflammation and maybe make the problem worse. So we've all had those patients that, you work on them and they actually flare up instead of feeling better. All right. So any questions there, Kyle? Anything else you want to touch on?
I think, off cam, we were having a conversation about the body being primed to then have a capsulitis reaction after a peripheral trauma. And we do have one question. So a proximal humerus fracture would qualify as a first source of trauma. And I guess the answer is it could be if it's traumatic enough. But going into some of the dysfunctions that we'll talk about in a little bit, that capsulitis could be primed at a low level or below threshold state of interstitial inflammatory stasis because of more of these proximal dysfunctions. Is that how you would describe it as well?
Yeah. So Kyle and I were talking about this recently, and many of these projected inflammations, neurogenic inflammations coming out from problems in the spine, like ligamentum flavum, they will give you a subclinical, meaning you have a capsulitis, you have lost range of motion, but it's not to the point where you're going to seek medical treatment. You're just kind of stiff, and it has taken up some of that capsule flexibility. So then that person could have a fall, or they could go play sports or something pretty innocuous and then damage that capsule locally because it was already stiff. Okay. So, clearing out some of this subclinical dysfunction, some of this neurogenic inflammation, you can free up the range of motion, just give people back their flexibility before they have an all-out bout of capsulitis or fasciitis. But yes, any local trauma could set in a capsulitis. It also may not, depending on the neurology. But let's say you have a pre-existing problem of at T3-4, C6-7, that's low grade. So, you'd have some lost range of motion, but you really don't have pain. And then you get a minor or a moderate insult to that shoulder, it could then be enough to wake up, add that next layer of inflammation, and it becomes symptomatic. Okay. So, every patient's a little bit unique, but again, where we're going to struggle as therapists is if we don't understand the complexity of the science, this neurogenic inflammation and these, muscle guarding reflexes and the sympathetic nerve activation, changing blood flow. That's where all the science is going now. The idea that, it's just scar tissue, just break it up. The question is, why is there scar tissue? Why was there inflammation there? Why do you have pain on both sides? You need to be looking at the pathophysiology, the modern science, the modern tissue science to really answer these questions. And then if it's all because of inflammation, which we know so many chronic diseases, are linked to that, what techniques can we use to specifically address that inflammation, kind of finesse this problem rather than trying to force through it? Okay, and that's kind of where we're headed now. So how does fascial counterstrain work to remove inflammation? Well, this is one of the many slides that we have in our foundations class. But basically what we're going to do is, decompress or unload that area of primary inflammation. And we go through an assessment process, which we won't get into in this particular webinar, but it tells us where the primary inflammation is, which is key. Then we decompress that tissue, basically slacken it, create a vacuum, and then there are all these little anchoring filaments on all these pre-lymphatic channels that anchor to the cells, and they're elastic. So when you slacken that, these little valves will open up, it creates a negative pressure, and it just sucks all that fluid into that vacuum that we made, and then the lymphatics can then pump it out. So where it's trapped in the interstitium, we're going to unload it and drain it out. Takes about 40-45 seconds, but as that inflammation starts to come out, the pain drops down, the muscle guarding drops down, that sympathetic nerve activation instantly changes, the arteries open up, the veins open up, the flow restores, you actually feel a pulsation under your finger, and then it flushes from there. So the body continues to work on it after 45 seconds, but we've knocked out enough of that inflammation to kick back in the lymphatic pump, restore the perfusion, relax the muscles, get enough of that TGF-beta1 out of there that you see the change clinically. And it's just, it's elegant. It's a finesse way of doing it. And, patients often say, how did that happen? It didn't even hurt. It's because we're targeting the problem, which is trapped inflammation. Anything else?
And the impact of that trapped inflammation on the mechanoreceptors and nociceptors that are in that tissue. So it's the
so when I say to patients, they're like, how does this work? I say, we find and remove inflammation. Okay, trapped inflammation, which we now know through the studies is at the root of a lot of chronic disease. I say where it gets complex is, what does trapped inflammation do? Yeah. That's where you can talk for hours, okay? Because you get into all those reflex arcs that we already touched on.
Yeah.
So let's go forward then, and a couple examples. I'm going to show you guys a couple clinical examples. So in our musculoskeletal spinal ligament and myochain class, which is a class you could take as your second class after foundations if you're an orthopedic therapist and you wish to take that class as your number 2, we have various different techniques that can impact capsulitis, and this is our upper extremity C6 myochain. So those of you who are familiar with Meyer's anatomy trains, I call them myochains, but they're very similar to those. There's a lot of overlap, but they're just proprioceptive myofascial units that not only do these releases help all the myofascia free up and help that kind of pain, a lot of these myochains anchor into the capsule. And this particular chain here, which goes from the thenar eminence into the flexor mass and all the way into the pecs, clavipectoral fascia, it anchors right in to this anterior capsule and actually tightens up this coracohumeral ligament. So this is one of the techniques that relates to C7, that when we release this, will help free up the anterior capsule. So this is a myochain impacting a small part of the capsule. So there's the release. We gave all these releases, these shortening techniques, nicknames. We call this one I'm the Boss. And we shorten that entire myochain all the way back, and I'm monitoring that capsule. So after that release, all that muscle tension will disappear. You don't have to do any massage on it. You don't have to stretch it. And a large part of that anterior capsulitis will go away. And this is one of many myochains that we go through in our musculoskeletal myochains and ligaments class. And
but a therapist with joint skills, Brian, what might they notice at the glenohumeral joint prior to this release being done?
Yeah, it would be just a classic, anterior capsule tightness. So if you did a joint mob, you would trying to stretch that anterior capsule, from posterior to anterior would be, tight and or painful. They would have a limitation in horizontal abduction. They'd have a limitation in external rotation. But this particular one wouldn't necessarily give you a full capsular pattern, whereas the ligamentum flavum we'll talk about, will tighten up the entire capsule. All right, so this is more of an anterior shoulder pain with like some limited external. Now let's get into, as I put on the slide here, the secret sauce that's based on neurogenic inflammation of capsulitis, fasciitis, and even synovitis that progresses eventually to osteoarthritis if you don't treat it. And that is the ligamentum flavum. So as far as I know, that we are the only ones that teach this in the world. If someone else teaches it, they took it from our curriculum years ago. But the ligamentum flavum, when inflamed, and this is the ligamentum flavum, it's called the yellow ligament, and it's deep in that area near the spinal cord, and it basically connects lamina to lamina. They're all individual, and they're on that posterior side of the spine there. And when this is inflamed, you will see it neurogenically produces inflammation very specifically to capsules. And that's something that was empirically figured out in the clinical setting. But we have theories as to why that's occurring. And we have that on the next slide. By the way, this particular ligament itself, when it contracts and it tightens, it impacts, spinal stenosis. So it's great for your patients with neck pain. That lady that you saw on the video, her neck also freed up because I targeted these deep ligaments. So it could just present as neck pain or a pinched nerve, but it does generate neurogenically capsulitis through this reflex arc we've been talking about. So this is it's a more modern science looking very carefully at the ligamentum flavum, and this is the ligamentum flavum here. It turns out there are what are called epidural or meningovertebral ligaments, and these are little slips of dura that basically go from the canal or the ligaments into the dura that hold the spinal cord in the center of the canal to keep it safe. And when you get inflammation and tightening and contraction of a ligamentum flavum, it actually pulls on these little epidural ligaments and actually irritates the dura. So that additional inflammation into the deepest part of the cord makes a very aggressive downstream neurogenic inflammation. Not to mention that ligamentum flavum can create inflammation, all around this area. I'll go back. There are cases where it gets so thick and tight that it rubs right on the cord itself, and that's why it can cause such severe pinched nerve symptoms. Well, again, if you start rubbing on the cord and tightening up the dura, you can cause another type of inflammation, not neurogenic, but neuroinflammation, which is inflammation caused by the central nervous system immune cells that are called microglia. And that creates central sensitization. So because of the proximity of this ligament, you can just get a lot of inflammation produced, and it's very aggressive capsulitis downstream is the clinical presentation. So let's go ahead then. This is a chart that's in our musculoskeletal spinal ligament myo chains class. And these are the segments of ligamentum flavum at each segment of the spine and what type of capsulitis it produces. So you'll see here that the C1, C2, C3 ligamentum flavum dysfunctions affect the TMJ. And those of you who know TMJ and do a lot of headache work, you'll know that the spinal trigeminal nucleus is a convergence of the trigeminal head nerve, head pain nerve, TMJ nerve, with cervical 1, 2, and 3 afferents. So that C1, C2, C3 blends right into trigeminal and gives you jaw stuff, okay? And of course, chronic headaches. Then as you go down, each individual level gives you a different capsulitis. There's your thumb for CMC at T4. There's your glenohumeral joint at T3. And as you go down further and further, you'll see some of these actually aren't just ligaments. They are, for example, the plantar aponeurosis, which we'll talk about in a second, but that can give you plantar fasciitis, okay? So patellofemoral capsulitis, hip joint capsulitis, and, basically level by level, you can find this neurogenic inflammation being produced out from the ligamentum flavum. Any comments there, Kyle, before we move on?
Well, we were talking about this a little bit off cam too, but I have a question from a student related to spinal cord injury patients with high tone, and might LF be involved there too? And then I was also thinking too, segmentally, obviously ligamentum flavum, And then the picture that you were showing looked like the LF could be putting a significant amount of pressure on like epidural adipose. So just from a multi-system standpoint, how often are you seeing the sort of stacking of dysfunctions around one spinal segment?
Yeah, almost always. So what Kyle's saying there is, do we find very often, a one and done, one release person is fine? No, not at all. The body is a wonderful compensator. So, and people tend to ignore subtle, things that are not significant pains. So they're not going to come to you, with just one problem. They've had a myriad of problems. So what you'll see in a person, with a really messed up shoulder is multiple things that are converging at T3, T4, multiple things at T1, T2, and all that inflammation is dumping back out, into similar structures in the shoulder. And then they come in for treatment. So, the proverbial peeling off the layers of the onion, of course, we do that even in counterstrain, even though we're draining things. After each layer, we reassess. We may do some visceral techniques that are innervated by the T3. We may, then jump into ligaments, then jump into myo chains. So you find yourself at these same segments over and over again with frozen shoulders, but it's a multi-system paradigm, layer by layer. And you can't say that all that substance P that's coming out into the shoulder at the T3 level is coming from ligamentum flavum. It's one of the best ones to target, but it is not the only thing that can produce neurogenic inflammation out from that segment.
Yeah. So with a spinal cord and injuries in high tone, a series of LFs.
So that is, I have that slide at the end. So that was clearly a counterstrain student that was asking that.
I believe so.
I'll get into that in a second, and that's when we're getting into spinal cord neurons inflammation at that deep level. And by the way, those of you who aren't counterstrainers, we keep talking about this musculoskeletal class. There's 3 different musculoskeletal classes, and then we have one of the ones we recommend you get into very early are the venous lymphatic classes, and draining all the lymphatics and the veins of the body, and even the spinal cord. We can directly drain the epidural complex and the anterior and posterior spinal veins and really get some of this central sensitization right out of the cord using these vein techniques. So there are many ways to take these complex, centrally sensitized, I heard everywhere patients and just target the depth of the inflammation. Is it in the periphery? Is it in the spine? Is it in the cord? We've got techniques that we could apply depending on the complexity of that patient. So here is the ligamentum flavum technique for the T3, and it is at the spine. The ligamentum flavum is released with extension, side bend toward, and rotate away. So I'm actually side gliding straight in to side bend the person toward at T3, and then I'm lifting up that scapula to get some rotation away. And I'm fine tuning that release through the coracobrachialis muscle, which is a really nice muscle that kind of relaxes via muscle guarding reflex at the same time the shoulder capsule lets go. So we just fine tune our release till that muscle relaxes, tender point goes away, and then that tells us that that capsule inflammation has also drained out. And you may gain 30%, 40%, 50%. You saw the lady, she probably gained 50% of her motion back with that one release. But rarely is that entire capsule going on unlock, or I should say the whole shoulder complex with just one capsule release. We still might have to work on the scapula, work on some of the rib cage, work on some of the pleura, work on the AC joint. There's definitely multiple releases that you'll do on a typical patient.
You have
And
one.
go ahead.
I do have one question here that I like. And it's, do these lymphatic channels, these pathways between the interstitium into the pre-lymphatic channels, do they slacken naturally through normal or exercise body movements? And this is a question that I get asked a lot, because the IIS model that you've developed, it's not really counterstrain specific. Counterstrain's the best intervention to address IIS and our biased opinions. But really anything that works and has good carryover is going to have an impact on interstitial inflammatory stasis. And is that kind of how you would discuss that?
Yeah. So, without going through the full science of the, contracted pre-lymphatic channels and the TGF-beta1, everything, I would say yes. When we know in the research that people who do non-painful movement, like, walking or, trampoline bouncing, things that stimulate lymphatics, gentle yoga, gentle stretching, which can stimulate the lymphangion to pump, can help with chronic pain. So yes, there are other ways to do it, and people do manage to self-resolve things by finding positions of comfort. Dr. Jones used gross positions of comfort in his releases. So the version that I developed is much more specific, tissue specific. But he used these large positions where he would just fold the body over. Well, if you start to talk to people that are in chronic pain, and they'll say, well, I only sleep on my left side with my knees up with a pillow here. I don't sit in that chair. I love to sit in this chair. They have found ways to position themselves into comfort. And over time, keep going into these slackened positions, you can manage to self-treat. And when they say that, a lot of chronic pain tends to slowly get better over time, a lot, surely not all. I believe it's from people finding positions of comfort, self-treating, indirectly, not knowing what they're doing by unloading and decompressing and going into these positions that feel good. But when you start to see some of the complexity of some of these cases and how many different releases you need to do and how you need to do them all in kind of the same, period of time to really get enough layers out. A lot of these cases, you'll never accidentally do it. These positions and glides are pretty unique, and many times you're treating an area that's far distant than the area of pain. And so people are often, have knee pain, but it's coming from their spine. So they're always trying to put their knee in a weird position or massage their knee, but that knee pain is neurogenically produced from the back. So many times they're rubbing and stretching and foam rolling and getting massages on the area that is the projection. It's not the source. So that's the main point. Yeah. So anyway, so let's look at another one that we use all the time. This is the ligamentum flavum L4, and it causes tibiofemoral capsulitis. So this tender point is right on the tibial plateau, anterior medial border, right below the medial meniscus, anterior horn. And we again just use the same pattern. There's also a paravertebral point on the inner part of the paravertebral at L4, and then we use that same extension, side bend toward, rotate away of the trunk, which is rotate toward of the pelvis. So there I'm fine tuning that release via the tender point until that tender point turns off and that capsulitis resolves. Again, when you get a case of this, that person's anterior posterior glide, their tibia restores, their knee flexion and extension improves. They can limp in and walk out, and you did nothing but hold them in this lower trunk rotation position and fine tune it. So it is, that's why people often say, it's voodoo or it's magic. No, it's applied science. It just doesn't require pain. It requires very precise unloading and draining of specific tissues. So that's another one. And let's look. So, we showed you guys, a capsulitis treatment. We showed you guys a knee arthritis, osteoarthritis treatment. Again, same class. And now we'll show you plantar fasciitis. So the plantar aponeurosis, it relates to the ligamentum flavum and what it becomes, which is called the deep dorsal sacrococcygeal ligament. Beyond, it continues to blend down and continues to get a similar referral pattern past L5. But at L5, S1, and S2, you get these bands of tightness of the plantar fascia. It makes fibrosis and contraction of the plantar aponeurosis. And then, of course, when that's tight, it pulls on that calcaneal, origin insertion here and gives you this micro tearing in here. So we can do the same technique and monitor the plantar fascia. And if you get an L5 on one side, an S1 on the other, which is common, you can get bilateral fasciitis. Okay. So here we come in and I'm monitoring one of those bands. Okay. In this case, I'm doing that L5 band. And then I'm going to do the same treatment, fine tune it till that goes away. And that releases the tension in the plantar fascia, which then allows that calcaneal attachment to heal. And again, this can be literally in cases a one and done or 2 sessions and done, even with people with months of chronic heel pain. Why? Because again, this is a spinal treatment. This inflammation was neurogenically produced. And when we drain out that low-level back problem, that's why that goes away. And it can be on one side or it can be on both sides. And we all know we see a lot of bilateral fasciitis patients.
This is one of the best parts, I think, about the technique here is you can reduce IAS through a number of different ways: exercise, mobility, activity, or whatever. But how many people have this diagnostic process that in a plantar fasciitis patient leads them to L5, S1, S2? And certainly after you taught us all these techniques, you start to associate these segments with a specific joint. Like I know my shoulder patient, T1, T2, T3, T4. You start to kind of pick up the patterns or memorize the patterns. But so many people are just treating locally here, maybe a joint above, maybe up to the knee, but they're missing that diagnostic process that brings them all the way back into the spinal column, um, which I think just the connections that Counterstrain has mapped out for us is is one of the best parts of this technique for me.
Yeah, it's based on the science of segmentation of the spinal cord, what are called metameres, and you're talking dermatomes, myotomes, sclerotomes. There's this related embryological referral that occurs level by level. So and you see the same tissues become inflamed together because of this neurogenic process that we're talking. So people with cardiac problems, feeds into that T3/4, and they can also be the people with frozen shoulders. And again, a multi-system paradigm, which is what we have, where we treat, all the inflamed tissues, not just the musculoskeletal stuff. But what we do in the musculoskeletal is very unique. We're going to be treating cartilage. That's the class that Kyle teaches. We treat, labrums and menisci and discs and, pubic symphysis and manubrosternal junctions and TMJ cartilage. That fibrocartilage also can be released and give you instant changes in range of motion and pain. Again, it's a very unique paradigm, even when we use it for the musculoskeletal pathways, and it's indirect. And I don't want to overemphasize or underemphasize, I should say, the power of the diagnostic tender point. So even if I said to you, that's an L5 ligamentum flavum problem creating that person's fasciitis, you'd be like, okay, what do I do about it? Do I mob it? Do I give them double kneaded chest?
Right.
We drain it, and that position, which only the tension in that plantar fascia tells us we have found the perfect position. We know we've drained it because through that reflex arc, the tension in that fascia drops down, the tender point disappears. And so we don't, there's no way to know what's going on inside short of monitoring the distal projection and fine tuning it. So without the diagnostic tender points, you even if I told you decompress the ligament flavum, you probably couldn't do it because you wouldn't know how to monitor the effectiveness of your treatment. So it's the magic of the tender point. And then we have assessments that tells you this is a ligamentum flavum problem. This is an anterior spinal ligament, posterior spinal ligament. This is a myochain. This is a vessel. We have layers of diagnostics that happen before the treatment that you're seeing. All right, and then let's jump down one more time. This is where some of the current counterstrainers we're already alluding to. Are there things that are deeper in the central nervous system that can give us this massive motor tone and capsulitis presentation? And the answer is yes. Okay, so there are 4 classes coming in the counterstrain curriculum that are related to the deep spinal cord and brain stem. Many of you, if you start into the curriculum today, these classes will be there when you get to the top of the curriculum. But we are going to be treating, and we do treat, the central nervous system motor and sensory tracts. And it turns out inflammation of the extrapyramidal, which are the involuntary motor tracts, causes extreme neurogenic muscle tension, like you could see with a stroke, or for example, like hammer toes, that tension in all those toes, and multi-segmental capsulitis. So just give you an example of a patient I saw today. The vast majority of my patients, they'll come in for 3 days from out of state, and I'll treat them 3 days intensively, and then out they go. And this guy came in with his main complaint was, after a severe whiplash accident, he's had photophobia, he's had, auditory sensitivity, he's had chronic headaches and migraines, chronic neck pain. And he happened to also mention, as I was working on that, he's like, I also got a lot of leg pain and a bad knee, which doesn't allow me to even walk. And the guy actually is a retired chiropractor out of DC. So I was able to talk shop with him. And so I finished up, got a lot of the pressure out of his head and, turned down a lot of that through draining of the brain and brainstem and auditory pathway. And then I said, let me take a quick look at your leg here. So I ran down to the meniscus, and what I felt instantly was that he had a capsulitis in his knee. And then I went down to his ankle, I went down to his foot, and I looked, and he had hammer toes as well. So he had knee capsulitis, he had tibiofemoral, he had proximal tib fib, he had distal tib fib, he had talotibial, foot intrinsic, he had capsulitis all the way down the leg. The whole leg was rigid and forming hammer toes. And what that is inflammation of one of the reticulospinal tracts, which basically causes, tension of the flexors or extensors or weakness of the opposite, and multi-joint capsulitis. So I went back up, ended up treating his reticulospinal tract at L1-2, treated that deep part of the cord. His toes relaxed enough that I could bend them, and the capsulitis and all those joints, disappeared. And then I treated his meniscus. And I'm sure when he comes in tomorrow, he's not going to just talk about how his knee doesn't hurt as bad. He's going to say how his whole foot, ankle, leg just feels different because he had this developing multi-segmental capsulitis. And so again, when you see that, just people are rigid the whole way down, they've got motor tone, that is spinal cord inflammation. And that's something we do address with some of the more emerging advanced techniques in the curriculum.
I'm not sure how much of that you want to get into.
No more. Yeah. But let's just say that if you see a presentation of somebody who doesn't just have fasciitis, doesn't just have capsulitis, everything is rigid, and it's on both sides, by the way. Those are the deeper spinal cord inflammation patients. Okay. And those are not super common, but if you treat the most difficult cases in your area or difficult cases in the country, which I do, I treat this stuff all day long. And it will not respond to stretching. It will not respond to mobs. It won't respond to any of that stuff. You have to target the inflammation, and in this case, in the central nervous system.
Yeah.
And I threw this slide up just for you, people who are potentially going to, join us in this, this work. That all we talked about today are the three things in blue, and this is just a quick list of all the things that fascial counterstrain is commonly used for. But we just touched on three little areas and how the musculoskeletal class can really help you with those three difficult cases. I also
let me take you back to LF real quick. So a question here from a participant about monitoring the right heel or plantar fasciitis, the tender point for L5, but using the treatment position. And I think, without reading the description of the treatment position, it looks like left hip rotation, adduction. But explain kind of what we're doing there with that treatment position.
So at the spinal level, we need to create extension. So she's lying on her back. We need side bend toward the involved side, which is right side bending. And we need trunk rotate away from that side, which is the same as bringing the pelvis toward. Okay. So that's the components. And then what we teach you is the feel in the classes. So you're going to be in a position approximately like this. You'll have the person put a little extension on the toe so you can feel that taut band, that tender band pop out. You strum across it from lateral to medial, and they have this tender point right on there. And they're like, yes, right there, that hurts. And then we move the spine until we feel that band just drop. And when you get that position just right, it drops out and the tendon starts to, rapidly decrease. And we just stay there for about 45 seconds. So there are some skills that we teach you how to feel the bind and the back off. So you don't really need to position and poke and ask and poke and ask. You learn to feel it. So, high-level counterstrainers, we do the assessment, we find the point, they say, yes, that's it. We treat it, and it resolves without getting a whole lot of feedback because we can feel that relaxation. As the inflammation drops down, so does the TGF beta 1. So the ligament tension drops down, the muscle guarding reflexes drop down. There's this palpable relaxation, which you can learn to feel objectively. It's not a subjective thing. Can you use subjective feedback? Absolutely. But we want to teach you to be objective about it. So you don't really need the feedback, once you become proficient.
Perfect.
So this is something you could very safely try on someone with bilateral fasciitis or one-sided fasciitis. It's safe to try it. But again, there's a lot of skills and there are other things that can cause fasciitis. But it's something, I throw in a webinar because they're very safe techniques. If you don't manage to release it properly, you can't hurt them. You just position, but you didn't get it to turn off. So that's the beauty of counterstrain. If it works or it doesn't hurt you, it's indirect, it's gentle. It's not like, popping someone's neck where you could have a negative outcome if you're a novice.
Any effect on burses with LF work?
So, burses are drained, via the lymphatic system. We actually treat those in our lymphatic classes where we literally decompress and put a little stretch on the lymphatics that go right into the bursa. So yes, there is a plantar fascia bursa that we actually, unload and drag the heel distally. So we do have a treatment of the calcaneal bursa, and that is another different version of what is sometimes diagnosed and called fasciitis. There are also inflammation of the distal branches of the sciatic nerve, which are the calcaneal nerves, and that's a neurogenic version of fasciitis. So there are several different things that can cause fasciitis, or what people call fasciitis. But that's why we go through the process. We have assessments that tell us, is this a bursa version? Is this a bone periosteal version? Is this a ligamentum flavum version? Is this a neurogenic version? And we would apply different techniques based on what kind we ran into. And it could be a combination thereof.
And usually is.
And usually is, yeah. So each treatment helps X percent. But again, if I had to pick, out of all the curriculum for fasciitis, if you said, I'm just going to leave you one technique, it would be the ligamentum flavum L5 to S2. It is the one that you see driving it the most commonly, but definitely not exclusively.
Perfect. Thank you. All right. Were there other slides that you wanted to get into?
Yeah, I just wanted to say, first of all, this is, if you guys, the paradigm of the trapped inflammation is a published, paradigm. It's something we go over in the foundations class. If you want to, this is a open access article that describes how the inflammation gets trapped in the body. It was published in a major journal in 2021, and Frontiers of Musculoskeletal Pain. And for years, it was the #1 most downloaded and read article in that journal all time. So it's been very well received. It's in the 99th percentile for downloads and reads. So you can read that before you get into the class, just to understand about this trapping of the inflammation, to adequately describe how it's trapped and everything that it does once it's trapped. It took 147 citations and 6,300 words. So we definitely went into a abbreviated version tonight, but there you can take a snapshot of that and read that if you wish. And then if you're interested in joining us as fascial counterstrainers, you actually need to start in our Foundations of Fascial Counterstrain class through the Jones Institute, who's sponsoring our webinar tonight. There's the website. And basically in that class, we're going to teach you the basic assessments. We're going to go through the science behind the technique, and you will leave Foundations class with 40 techniques from 5 different systems. So kind of a sampling of techniques from the nervous system, musculoskeletal system, arteries, viscera, and veins. You'll get techniques, parts of each of those classes in the first class. So you'll leave with, 40 to 50 multi-system techniques and assessments you can start using on Monday morning from the Foundations class.